Hello and good afternoon, everyone, and welcome to the Spotlight on Knowledge Translation Methods and Tools webinar series. My name is Kristen Reed, and I am a research coordinator at the National Collaborating Center for Methods and Tools, and I will be helping to facilitate this webinar today. So thank you to those who have joined us this afternoon. Today we will be featuring the grade approach for appraising the quality of evidence and strength of recommendations. So to begin, I would like to quickly review a few housekeeping items. We ask that you please use the chat section on the bottom right-hand side of your screen in WebEx to post any comments or questions you may have during the webinar. We will have a designated open Q&A session at the end of the presentation, but we encourage you to please feel free to post any questions or comments you have throughout the webinar presentation. Also, please make sure to post your comments, questions to all participants, as others may have the same questions as you. Today, we recommend using a wired internet connection as opposed to a wireless connection. If you have any connection issues today, you can use the WebEx 24/7 helpline, which is posted on the slide, and this will also be posted in the chat section. We also have Grace available today to assist with any technical issues that you may have, so please feel free to send Grace a message through the chat function. So just to let you know that after today, the PowerPoint presentation will be made available in both English and French, and the English audio recording will also be made available on the NCCMT's website. So these resources can be accessed using the link posted in the chat section, as well as on our YouTube and SlideShare pages, and are generally posted within a week or so of today's presentation. So we have our first polling question today. So Grace, if you can open that poll, please. Really, we're just wondering who is watching today's presentation today with you. So we're wondering if you're just joining by yourself today, or if there are 1 to 3 of you, 4 to 6, 6 to 10, or if you're in a larger group. So if you could please answer this question in the poll panel on the right-hand side of the WebEx platform. Also please remember to select Submit once you have selected your response. So we're seeing a few come in. Most people are joining on their own, but we do have a couple small groups and also one larger group of over 10. So that's really great to see. So I would like to officially welcome everyone to the NCCMT Spotlight on Knowledge Translation Methods and Tools webinar series. Today we'll be featuring the grade, appraising the quality of evidence and strength of recommendations. We'll be posting links in the chat to the registry page for this tool, and we'll also have the links to the website as we move along through the presentation. So today's webinar will include a presentation by the developers of the grade approach, as well as a user story from a group who has used grade in practice, and they will also share their experience. So I will introduce our presenters shortly, but for those of you who may be unfamiliar with the National Collaborating Center for Methods and Tools, we are one of 6 national collaborating centers across Canada, funded by the Public Health Agency of Canada. We here at the NCCMT are located at McMaster University in Hamilton, Ontario. And while the other NCCs focus on the use of research evidence in specific public health content areas, we focus on improving the access to and use of knowledge translation methods and tools for public health professionals in practice within Canada. So we're not content specific, but we do offer methods and tools that can be applied across many different areas of public health. The National Collaborating Center for Methods and Tools has many products and services available through our website, a few of which we have listed here. So today we will be highlighting a tool that is located in our registry of methods and tools. And we'd also just like to take an opportunity to highlight some of our other popular resources here. So the NCCMT offers a variety of online learning opportunities through our Learning Center, as well as videos such as our Understanding Research Evidence series, which offers short, plain language videos explaining key terms and concepts for interpreting research evidence. So we have our second and final polling question before we get started with our presentation today. And we're wondering how many participants joining us today are familiar with the grade approach that we will be discussing. So whether perhaps you are not familiar with the tool at all, or perhaps you've heard of the tool, or maybe you have used the tool in your practice. So as responses come in, we're seeing that we do have some people who aren't familiar with the tool, which is great to see. So hopefully we are able to have a very informative discussion. And there are also people who have heard of the tool and actually who have also used the tool in their own practice. So that's really wonderful to see. So with that, I will move on to the main event. So I would like to formally introduce you to our presenters today. It is my pleasure to introduce Dr. Gordon Guyatt, Distinguished Professor in the Department of Health Research Methods, Evidence, and Impact at McMaster University, who will be presenting on the development of the GRADE approach. And we'll also have Sarah McDowell from Health Quality Ontario, who will be sharing her experience with the tool as well. So thank you very much to our presenters today for coming. And Gordon, if you're on the line, I will pass it on to you.
Okay, thanks very much. Everybody can hear me? Sarah, can you hear me?
Yes, I can hear you.
Okay, good. I presume that everybody can hear me then. Now, I just have to remember maybe to move the slides. We had something that was sent before, but I can't seem to see how I move the slides forward. Somebody there can give me some advice?
Absolutely, yeah. So if you look at the very top of the page or the window there, you'll see a number. It'll say slide 9.
Oh, yes.
So there's 2 arrows on those sides.
Yeah, just to the right and left of that. Okay, great. Okay. So this is going to constitute a brief introduction to the GRADE approach to rating quality of evidence and grading strength of recommendations. I'm sure Sarah will say this, but when we get to her part of the presentation, the grading approach of strong and weak recommendations is not something that Health Quality Ontario does, and the focus will there be on rating the quality of the evidence. So I'm going to give some background to GRADE, talk about these 2 key steps, and in the previous slide I called it quality of evidence, and here I called it the confidence. There's a third term, which is certainty. So you will see in the GRADE literature 3 words that mean the same thing: quality, certainty, or confidence. So these are all synonymous and have to do with what could be described with another word, which is the trustworthiness of the evidence. And then the strength of recommendations, and going to show you an evidence profile, and then the strength of the recommendations. So the group started to meet, the GRADE working group, in the year 2000. The first paper describing the method was published in the British Medical Journal in 2004. Subsequently, in 2008, the British Medical Journal published a 6-part series. This was designed particularly for users of GRADE, and I think we were thinking mainly of clinicians at that time. Subsequently, we have a series of publications in the Journal of Clinical Epidemiology. It says there a 17-part series. The 18th part has just appeared, and there will be more. These provide considerable detail on how to use the GRADE approach for systematic reviewers, guideline developers, and folks doing health technology assessments, the third group that might be using GRADE. There's also 2 chapters about using GRADE for systematic reviews in the Cochrane Handbook. So we've been actually quite happy with the uptake since the first publication in 2004, and there are now over 100 organizations who have adopted GRADE. Highlighted are some of the ones that are more prominent, including the World Health Organization, prominent American organizations like the American Thoracic Society and the American College of Physicians, the Cochrane Collaboration, NICE, who does guidelines for the National Health Service, the leading health technology assessment agency in the world in some people's view, which is the Swedish Technology Assessment, SBU, the Centers for Disease Control in the United States, and for frontline clinicians in all over the world, UpToDate and Dynamed. UpToDate has over 10,000 graded recommendations. So very wide uptake across many organizations and many varied organizations, including physicians groups, these revolutionary textbooks like Dynamed and UpToDate, international groups, World Health Organization, and the Cochrane Collaboration. So one reason you should be congratulating yourselves now in listening into this webinar is that you're going to be seeing almost whatever you do. If you're involved in looking at systematic reviews or guidelines, you're going to be seeing lots of grade. So what are we grading? 2 components. The first component, alternatively labeled as the quality of the evidence, the confidence in the evidence, or the certainty in the evidence, which can be conceptualized as a continuum from no confidence or certainty to totally confident or certain. However, GRADE takes this certainty as a continuum and divides it into 4 categories: high, moderate, low, and very low. Some organizations combine the low and very low. For example, UpToDate just has high, moderate, low, where the low effectively combines low and very low. The strength of recommendations, even a simpler categorization, simply binary, strong recommendations and weak recommendations. You will find that there are organizations who don't like to label their recommendations as weak, and so they use alternative words, contingent or discretionary or contingent, different words that people, or conditional, perhaps actually the most popular of those is conditional. So you'll see strong and weak recommendations from some organizations, strong and conditional recommendations from other organizations. So, determinants of quality. Randomized trials start as high in this high, moderate, low, and very low classification. Observational studies start as low. However, there can be 5 limitations that can be applied to either randomized trials or observational studies, most important perhaps with randomized trials which start as high. So randomized trials can be rated down for problems with risk of bias, inconsistency, indirectness, imprecision, and publication bias. And I'm going to go through and provide some details for each of these categories, reasons that we might rate down the quality of the evidence. So for randomized trials, perhaps the most popular instrument for rating risk of bias in randomized trials is the Cochrane's Collaboration Instrument. Well-established issues in rating risk of bias include concealment of randomization, whether the intention to treat principle is observed in the analysis, whether patients, caregivers, those collecting the data, those adjudicating outcomes, and those analyzing the data are blind to whether patients receive the intervention or control, and the extent to which follow-up was complete. More recently, people have described selective outcome reporting, where unfortunately well documented that sometimes investigators collect outcomes, and for particular outcomes, when they don't like the results, they don't bother telling you about them. We also know that trials stopped early for benefit systematically overestimate treatment effects, and that overestimate can be quite large when you have small numbers of patients and small numbers of events and very large effects that are needed with small numbers and more events to stop early. So those are issues of risk of bias. If the randomized trials are concealed, followed the intention to treat principle, were blinded and complete follow-up, no evidence of selective reporting, and they didn't stop early, one has no concerns about risk of bias. At the other extreme, studies, if all the studies are unconcealed, unblinded, and lost half their patients to follow-up, you're definitely going to be rating down for risk of bias. For sometimes you may have some studies that look better and some studies that look worse in terms of risk of bias, and then there are judgment calls. And a point to make as far as this is concerned is that applying grade does not prevent you from having to make judgments, does not obviate the need for judgments. Judgments will always be there. The great merit of grade is not that it means that you don't have to make judgments. It provides an explicit and transparent guide to making the judgments. So, risk of bias, one reason for rating down, the next, imprecision. So imprecision comes when you have small sample size and small number of events, which will then lead to wide confidence intervals, means that one is uncertain about the magnitude of effect. And grade does ask reviewers to focus on the confidence interval. The wider it is, the more likely you are to rate down for imprecision. But the issue then arises is how wide is too wide? And the primary criterion is would decisions differ at either end of the confidence interval. So the next slide provides 4 hypothetical results of a systematic review and meta-analysis. 0 represents the line of no effect, no difference in the outcome of interest in the treatment or the control group. 1% is an absolute reduction in bad events as a result of the intervention, and the example we often use for this is atrial fibrillation and preventing stroke, where with a bleeding risk of 30 in 1,000, a stroke reduction of 10 in 1,000 may be seen by the typical patient as an important benefit that would be worth using anticoagulants in the face of the downsides. The top of the slide with the point estimate and confidence interval, you see the point and estimate and the confidence interval is entirely to the left of your threshold. So your threshold means above your threshold, treatment is worthwhile. Below your threshold, the benefits of the treatment are insufficient to make up for the downsides. In the top point estimate and confidence interval, the entire confidence interval is to the left of the threshold, and so it doesn't matter if you picked the point estimate, the top of the confidence interval, or the bottom of the confidence interval. There are entirely above the threshold, and imprecision is not a problem. In the second one, the point estimate is above the threshold, the upper boundary of the confidence interval is above the threshold, but the lower boundary is below. We thus have increased uncertainty about whether our treatment effect is big enough to make it worth giving treatment, and the confidence interval indicates that probably it is, or quite possibly it is, but it may not be. That lower boundary of the confidence interval makes us uncertain whether the treatment effect is big enough to actually recommend the treatment, and as a result, we're going to be rating down for imprecision. The third, the entire confidence interval is to the left of our threshold, and even in the biggest possible treatment effect, it's lower than our threshold for using the treatment, and there's no problem with imprecision. We're likely going to be recommending against the treatment as a result of the fact that even the upper boundary of the confidence interval suggests that treatment effect is not big enough to warrant using it given the downsides. And the final one, you're probably going to be recommending against the treatment on the basis of a point estimate that is substantially below that threshold for using the treatment, but it remains possible if one looks at the end of the confidence interval representing the largest possible effect, treatment may still be greater than your threshold, and so that introduces an element of uncertainty, and we're going to be rating down there for imprecision. So we've dealt now with risk of bias and imprecision. Another reason for losing confidence or certainty in the results is inconsistency. So how do you look at, how do you judge inconsistency? You can look at the point estimates from study to study, and the larger the variation in the size of the effect across studies, the more concerned you are about inconsistency. If the confidence intervals are widely overlapping, you have less concern about inconsistency. If there's minimal overlap in the confidence intervals, you're much more worried. And there are two statistical tests that provide some guidance in judging inconsistency, the statistical test of heterogeneity and the I-squared. So I'm going to spend a little more time about this. And if I can get the slide to move, there we go. This is the I-squared. The I-squared represents the proportion of the variability that requires explanation by true between-study differences. So an I-squared of 0 means that all the variability can be explained by chance. You do not have to invoke any true between-study variability. A low I-squared, say around 20%, one gets only little concerned. When you approach 50%, you're getting more concerned. 75%, you're very concerned. And if you're near 100% in your I-squared, you have sufficient variability that one might wonder why you're pooling at all. So I-squared, the proportion of the variability attributable to between-study differences. The closer you are to 0, the less you're concerned. The closer you are to 100, the more you are concerned. I don't know why I'm having, there we go, difficulty changing the slides. So this is an example of what we call a forest plot. It presents the point estimates and confidence intervals from 7 studies that addressed the issue of what is the effect of vitamin D on non-vertebral fractures when people take vitamin D to try and prevent fractures. Let us, if you look at the pooled estimate is an 18% relative risk reduction with a confidence interval from a 71 to a 2% relative risk reduction. Now let us focus on what we think of the inconsistency. You see that all studies but one, the point estimate is on the benefit side, which is to the left of no effect. You have one study with a point estimate on the other side, and some studies with quite very large apparent effect. So you've got a substantial amount of variability in the point estimates. In terms of overlapping of the confidence intervals, most of the confidence intervals overlap widely, but if you look at the top first study and the second, there's very little overlap. If you look at the second study and the third, there is very little overlap. If one asks the question, can chance explain the variability in the results? The null hypothesis for this test is that if the true effect was the same across the studies that are available, how much would you see variability as great or greater than you see here? The answer in this case is 0.05 or 5%. So if there was a true effect was the same in all these studies, you would see simply by chance variability as great or greater than you see here. of the time. The I-squared is in the moderate range, but enough to give us some concern, 53%. Would one rate down for inconsistency here? I chose this in a way because it's something of a close call, although I think when I've presented this to audiences, most people would rate down for inconsistency, saying that we lose certainty or confidence in the effect. The degree of inconsistency is such that we lose some confidence, appreciable confidence, in that pooled estimate. So what do you do when you see heterogeneity or inconsistency that's concerning? What would one hope that the systematic reviewer does? What the systematic reviewer, we hope, would do would be to look for explanations of that heterogeneity. And that may come from the patients, the interventions, the outcomes, or the methodologies. So the patients may be older or younger, the interventions may be higher or lower dose, the outcomes may be measured over 1 year or 5 years, and the studies may be at high or low risk of bias. And any of those might explain the heterogeneity, and one would like the systematic reviewer to look. Ideally, the systematic reviewer has considered in advance that they might see heterogeneity and what the explanations might be, and would generate a priori hypotheses to explain the heterogeneity. And they did that in this case, and the investigators, one of the things they focused on to explain heterogeneity was dose. And they looked first at studies that used greater than 400 international units of vitamin D, and now you see that all the point estimates are in the benefit side. They're not that far apart. The confidence intervals are widely overlapping. The p-value for the test for heterogeneity is now considerably higher, 0.26. The I-squared considerably lower, 24%. So here, once we restrict the results to those studies that used a higher dose, it appears that we no longer have troubling inconsistency or heterogeneity. Whereas if we take the two studies that used a dose of 400, we see that both showed very little difference from no effect, one on one side and the other on the other side, one suggesting slight benefit, the other suggesting harm, but quite wide confidence intervals and a pooled estimate that suggests no effect. So now we have a possible explanation of heterogeneity. If we believe it, then we would say with higher doses, vitamin D is effective, and with lower doses, it is not effective. And within each of those subgroups of studies, one no longer has troubling heterogeneity. There we go. So the next issue, we have now dealt with risk of bias, inconsistency, and imprecision, and now we consider an issue of what Grade calls directness. And the idea of directness is that the patient you have before you and the context that you have before you may differ from the trials. So I work as a specialist in general internal medicine, and when I am on the wards nowadays, quite a substantial number of my patients are over 80, and more, quite a few of my patients are over 90. There are not many 90 years olds that have been enrolled in the randomized trials that I use to guide my practice. And so I have some hesitations. I may have very nice randomized trials that suggest a particular benefit for an intervention, but I'm a little hesitant when I come to apply that to my patients who are over 90, because there were very few 90-year-olds in those trials, and they may respond differently. So as a result, one considers this a source of indirectness. If the populations are older, sicker, or have more comorbidity than those included in trials, one might hesitate to apply the results, and thus, in the Grade way of thinking of things, one rates down the quality of evidence for indirectness. We may also have indirectness of the interventions. For instance, we're now switching more and more to direct anticoagulants. Warfarin was at one stage the only anticoagulant we had available. It required close monitoring. Trials may have undergone close monitoring and avoid out-of-range INRs, which is the units by which we measure warfarin effect. But in clinical practice, the care with which it is monitored may be much less, and that would attenuate treatment effects and perhaps increase the risk of bleeding in the community, and one might hesitate to apply trial results to the community and thus rate down for indirectness in interventions. Then we have possibilities of indirectness of the outcomes. So we're interested generally in patient-important outcomes. If the trial has measured a surrogate outcome, we're going to rate down for indirectness of the outcome. For instance, many trials in patients with diabetes, we would like them to measure macrovascular events, strokes, heart attacks, and peripheral vascular disease, or microvascular events, problems in the eyes or the kidneys, but instead they say the new treatment lowers glucose. We may hope that this lowering of glucose would translate into difference in macro and microvascular events, but it may not. And as a result, if all we have is evidence that the glucose is lower with treatment, then we will rate down for indirectness of the outcome. So we can have indirectness of the population, the intervention, or the outcome. There is another type of indirectness, and that comes from indirect comparisons. Generically, we are interested in A versus B. The available data from randomized trials, there are no direct comparisons between A versus B, and we must make our inferences about treatment effectiveness from A versus C or B versus C. For instance, alendronate and risedronate are two bisphosphonates used to prevent fractures. They haven't undergone head-to-head comparisons, but both have been compared against placebo. Alendronate, as it turns out, in systematic review of randomized trials, shows about a 50% reduction in fractures, risedronate 35%. One might infer that alendronate is superior to risedronate from this, but one would be considerably less confident from this indirect comparison than if one had a head-to-head comparison between alendronate and risedronate. Publication bias is the fifth reason. We've gone over risk of bias, imprecision, indirectness, inconsistency, and unfortunately, you can have low risk of bias, consistent, precise results, no problems with directness, and still be misled if particularly the usual thing is that the negative results have been withheld, you never see them, and so the results you have available to you are biased. High likelihood of publication bias, we rate down our quality of the evidence, when to suspect it, a number of small studies that are industry sponsored. One can also use something called a funnel plot to look at publication bias. On this plot, the x-axis is the magnitude of the treatment effect, and where, say, big treatment effects are to the left, small to the right. The line represents the point estimate when you would pool across studies. The precision of the estimate is on the y-axis. In other words, the bigger the study, the more events, the farther up that y-axis you go. And what you see here is that if there is low risk of bias in the large studies, then they are going to be close to the truth. If there is low risk of bias in the moderate-sized studies, there's going to be, because of their imprecision, more variability, but the results will cluster uniformly around the truth. With small studies, because of their imprecision, individual study results may be a long way from the truth, but once again, if they are all at low risk of bias, the results will distribute symmetrically around the truth, and that's in fact the great advantage of meta-analysis, is that you pool the data from all these studies and thus enhance precision, narrow your confidence intervals. So what there should have been next, and doesn't appear to be here, is the next slide showed what happens when we have, when when there may be publication bias. Can people see my pointer? Anybody tell me, Sarah, is my...
No, unfortunately, you actually, on the top left-hand side, you'll see something that looks like a pencil. If you click on that, it'll let you draw on the slide.
Okay. Well, thank you. I've clicked. Sometimes one may see, so this is drawing, one may see that this lower corner is missing you draw this funnel plot and the lower corner of the studies is missing. In other words, you have small studies that have big effects, but you don't have the corresponding small studies here. So you have a missing quadrant in your funnel plot, and that missing quadrant in your funnel plot suggests publication bias. So that's so another way, small studies, all industry sponsored, you're suspicious, and in a situation where you have an asymmetric funnel plot, you have small studies showing large effects, but no corresponding small studies in the other direction. That's another reason for suspecting publication bias. So we've now completed all the reasons for rating down. Randomized trials start as high-quality evidence, but may be rated down for risk of bias, imprecision, inconsistency, indirectness, or publication bias. Small studies observational studies start as low-quality evidence, but can be rated up most commonly by a large magnitude of effect. Very large magnitude of effect, we can go from low to high quality evidence, moderately large effects from low to moderate. The situation we're talking about is everybody used to do badly, almost everyone does well, and there's a quick action. So one example, we don't have randomized trials of hip replacement for osteoarthritis, but because the effects are very large and happen quite quickly, we are very confident we have high-quality evidence that hip replacement benefits patients with osteoarthritis. Other sort of situations like this are dialysis for people with renal failure, epinephrine for people in anaphylactic shock, insulin for people in diabetic ketoacidosis. So there are situations when we don't have randomized trials, when observational studies can nevertheless yield high-quality evidence. So this now summarizes the great approach to certainty of treatment effects and everything I've said thus far. So randomized studies start as high certainty, confidence, or quality of evidence, but may be rated down risk of bias, inconsistency, indirectness, imprecision, or publication bias. Usually we only rate down one, but if there's very big problems in any of those 5 reasons for rating down, we might rate down 2. Observational studies start as low quality evidence, but they may be rated up to moderate or even high, most commonly because of a large effect, sometimes because of a dose-response gradient. So that then is the summary of the great approach to rating quality of evidence. One may, particularly when in a guideline, want to make an overall rating of the quality of evidence. And that is problematic because you may have high quality evidence for one outcome and low quality evidence for another. And what does one then say about the overall quality of the evidence? Often we may have higher quality evidence for benefit than harms, for instance. The traditional approach has been to ignore all but the primary outcome. One could have the overall rating, the lowest quality of any outcome, some blended approach. If high and low, you say moderate. What the grade has decided is the lowest quality of the critical outcomes. So you decide what outcomes are critical for your decision, and the overall quality of the evidence is the lowest of those. Grade then presents the summary of the results in what is called an evidence profile. This is an evidence profile for beta blockers in non-cardiac surgery, and it presents three outcomes: myocardial infarction, mortality, and stroke. You see in myocardial infarction that over 10,000 patients have been enrolled in 9 trials. We have no problems at all for risk of bias, consistency, directness, precision, or publication bias. We thus have high quality evidence of a 29% reduction in relative risk with a confidence interval from a 43 to a 16% relative risk reduction. What's important to patients is absolute effect, and that translates into 15 fewer myocardial infarctions in 1,000 patients undergoing surgery, with a confidence interval from 7 to 21 fewer myocardial infarctions. Mortality also comes from over 10,000 patients, this time in 7 trials. No problems with risk of bias, consistency, directness, or publication bias, but problems with imprecision. And so the problems with imprecision show when you get, so it's overall moderate quality evidence. You can see the point estimate is a 23% increase in mortality, but the confidence interval goes from anywhere a 2% decrease to a 55% increase, and clearly the implications would be different if it reduced mortality slightly versus an appreciable increase in mortality. In absolute terms, that means 5 more deaths per 1,000 if that 23% increase in relative risk were the truth, from 1 in 1,000 fewer to 13 in 1,000 more. Finally, stroke, again, from over 10,000 patients. Again, the only problem with our quality of evidence is imprecision, because the confidence interval goes from no effect to a almost 3 times increase in the risk of stroke. So here we have 2 outcomes with moderate quality evidence, 1 with high quality evidence. So following great guidance, if one was putting an overall rating of quality of evidence here, one would call it moderate. So we finished our discussion of quality of evidence and how grade presents the results of our pooled estimates across studies in relative and absolute effect, and the rating of quality of evidence. We move now to what guideline panels do, which are strong recommendations or weak or conditional recommendations. A strong recommendation means that the benefits clearly outweigh the risks, hassles, or costs, the downside, or the opposite. The downsides of the intervention clearly outweigh its benefits. 2 major reasons for rating down the strength from a strong to a weak or conditional recommendation. One is if you have low confidence or certainty in the evidence. If that is the case, and you're not sure of the benefits or you're not sure of the downsides, pretty difficult to say that the benefits do or do not outweigh the downsides. A second situation, you can have high certainty in the evidence, but if there's a close balance between the benefits and the downsides, differences in people's values and preferences may lead them to make different choices, and under those circumstances, a guideline panel would appropriately make a weak or conditional recommendation. So, for instance, consider aspirin after myocardial infarction, a 25% relative risk reduction, side effects minimal, cost minimal, and that's a reduction in very important events, including mortality. Benefit obviously much greater than the downsides, and a strong recommendation would clearly be warranted. We have high quality evidence of anticoagulants versus aspirin in patients with low risk atrial fibrillation. Anticoagulants decrease the risk of stroke, but unfortunately increase the risk of bleeding. Anticoagulants reduce it's a 50% relative risk reduction in stroke, but if your risk is only 1% per year, that would only be a 0.5% increase. Increase bleeds by 1 to 2%. And even though we have high quality evidence, there is a close balance, and we would rate, and we probably would be making a weak recommendation. So, aspirin after myocardial infarction, benefits clearly outweigh the downsides. Do it. Anticoagulants rather than aspirin and atrial fibrillation. We have high quality evidence, but because of a close balance between benefits and downsides, we're going to be making a weak or conditional recommendation. We like this binary distinction between strong and weak or conditional recommendations because it has very direct implications for practice. A strong recommendation means we believe all or almost all fully informed patients would make the same choice. A weak recommendation would be when values and preferences differ such that the choice would vary appreciably across patients. That has implications for the interaction with the patient in the busy, time-constrained clinician. A strong recommendation, you simply inform the patient, here's what we think you should do. A weak recommendation, you need to have shared decision-making to ensure the choice reflects the patient's values. How do you do that? A decision aid may help you. A strong recommendation, you might not bother with the decision aid if the guideline panel got it right. The end of that exercise is predetermined. A weaker conditional recommendation, you will use the aid. Quality of care, we're more and more concerned about. A strong recommendation is a candidate for a quality of care criteria. A weak recommendation is not, because the right thing to do varies from patient to patient. So, in conclusion, clinicians and policymakers need evidence summaries. They need summaries of the quality of evidence, and clinicians certainly look very often to guidelines. They need recommendations, but they also need to know whether those recommendations are strong or weak or conditional. We need explicit rules for both rating quality of evidence and strength of recommendations that are transparent and informative. We believe that GRADE takes a complex problem, makes it about as simple as it can be with transparent criteria that can be systematically applied. Increasing and now very wide adoption of the GRADE approach, which is one reason to get familiar with it. So thanks very much. Do we have questions here, or do we move straight to Sarah's presentation?
Thank you so much, Gordon. That was a really great overview and definitely gave us a lot to digest. So I will perhaps at this point ask people to start posting their questions in the comment, the chat box. Perhaps we will move on while people are thinking and typing to Sarah in your presentation about your experience using GRADE.
Sure, okay. Oh, I'm now the presenter. Okay, let's try. Okay, great. So hi, everyone. My name is Sarah McDowell. I'm the Manager of Clinical Reviews within the Health Technology Assessment Program at Health Quality Ontario. I'm certainly grateful for the opportunity to follow on from Dr. Guyot's presentation and just to share with you some perspectives on our use of GRADE. Just a bit of outline in the next 15 minutes or so. I'd like to provide a description of the HTA program at Health Quality Ontario and provide some examples of how we've used GRADE in 3 recent HTAs. So HCO has a legislative mandate to make recommendations to the Minister of Health concerning the Government of Ontario's provision of funding for healthcare services and medical devices. We achieve this mandate through the production of HTAs, or Health Technology Assessments, which are reviewed by the Ontario Health Technology Advisory Committee, or OTAC. This is a group of volunteers, a group of around 15 or so healthcare experts and individuals who offer the patient perspective. So our HTAs have 3 key components where we consider the clinical benefits and harms, the value for money and affordability, and the patient preferences and values for healthcare services and medical devices. So in terms of our use of GRADE, we've been using GRADE within our clinical evidence review component for quite a while, since 2004. So our team of clinical epidemiologists undertakes systematic reviews of the clinical literature, and then they use GRADE in their assessment of the quality of the body of evidence. And this is presented in addition to the health, economic, and patient engagement evidence to OTAC. After considering all this evidence, OTAC makes a binary yes or no funding recommendation, so whether the device should be publicly funded or recommend against public funding. And OTAC does not grade the strength of the recommendations, as referenced by Dr. Guyatt earlier. So hopefully that provided you with a bit of context of who we are, what HCO does, where we're coming from, and how our HCAs are used. Next, I'd like to present 3 examples of how we've used GRADE in some recent HCAs, acknowledging, of course, the tremendous work of the clinical epidemiologists Anna Lambrinos and Christine Lee, who helped to build these 3 HCAs. So in this first example, we examined the benefits and harms of mechanical thrombectomy in patients who have acute ischemic stroke. So the current treatment for eligible patients is intravenous thrombolysis, but this may not always clear enough of the blockages. So these newer devices may do a better job of clearing large blood vessels and helping patients recover from stroke. So our systematic review identified 5 RCTs ranging in size from around 50 to almost 500 people. And so we were able to undertake a meta-analysis for 3 outcomes, 2 of which are presented here, so the outcomes of mortality and functional independence. So there was certainly sufficient clinical and statistical homogeneity that allowed us to undertake the pooled analysis. And these nice forest plots are certainly very useful, as they certainly allow us, when we're grading the evidence, to really easily assess the consistency and the precision of the evidence for each outcome. We, of course, need to consider other components of the grade assessment, such as risk of bias and indirectness and publication bias, as Dr. Guyatt walked us through earlier. So overall, for the outcome of functional independence, and the primary outcome, so that was whether a person attained a certain threshold on a functional independence scale, we had a high level of certainty that there was a significant improvement when mechanical thrombectomy was compared with the intravenous thrombolysis. For the outcomes of mortality and hemorrhage, there was moderate certainty of no difference. And the quality, for these 2 outcomes, the quality evidence was downgraded due to concerns about imprecision due to small sample size, small number of events, and the concerns that the optimal information size may not have been met. And so all these outcomes, in addition to the clinical evidence, the economic evidence and the patient engagement evidence, was presented to OTAC. They certainly acknowledged the substantial clinical benefit demonstrated by the mechanical thrombectomy, as well as the favorable value for money, and decided to recommend in favor of public funding. And here we've got verbatim the actual funding recommendation that was made in February of 2016. So in this second example, we wanted to examine the benefits and harms of electrical stimulation for patients with pressure injuries as an adjunct or extra therapy to standard wound care. So in electrical stimulation, electrodes are applied directly to the wound bed of the pressure injury, to create a small electrical margin of tissue. So the proposed benefit that it will improve healing. So our systematic review identified 9 randomized control trials and 2 non-randomized control trials. So unlike that previous example of the mechanical thrombectomy, we were unable to pool any kind of data. That was mainly due to the clinical and methodological heterogeneity. So there was variation in how the electrical stimulation and how the standard wound care were administered, as well as different outcome measures reported. So in terms of the results, we were required in the end to do a narrative summary of the 3 outcomes that are described here. So the time it took for the wound to heal, complications associated with electrical stimulation, and the relative rate of healing. So in terms of actually undertaking the grade assessment, the same methods and same thinking was required as the previous example. Certainly when we did the risk of bias assessment, that's still in the same manner, using the same tools. but certainly there's that added challenge of not being guided by that nice forest plot to help us really have that quick and easy look at the consistency and precision. In this case, we did downgrade the evidence due to concerns over risk of bias or imprecision or indirectness. And so what we were able to conclude is that really we are uncertain whether electrical stimulation actually does improve average time to heal, reflecting by the low grade. Low grade of evidence for relative rate of healing. So again, we're uncertain whether electrical stimulation actually does improve the daily rate of healing. We certainly had a high level of certainty and confidence in the fact that electrical stimulation was safe. There was very few complications. So these results, in addition to the economic and patient engagement evidence, were presented to OTAC. The committee concluded that there was just too much uncertainty about the clinical benefit of adding the electrical stimulation to high-quality standard wound care. This is largely due to the small body of evidence and to variation in how electrical stimulation and standard wound care were administered. So given that uncertainty, OTAC actually recommended against publicly funding electrical stimulation. And that recommendation was made just late last fall, in November 2017. So in this third and final example, quite an interesting technology, we evaluated the benefits and harms of a retinal prosthetic system, which is actually designed to restore partial functional vision in patients with profound vision loss from a genetic disease called Retinitis pigmentosa. So the systematic review undertaken by the clinical epidemiologist identified a single cohort study of 30 patients, which reported data over 5 years. The systematic review identified a range of outcomes for visual function, quality of life, and functional outcomes. But just here in this slide, I'm just going to present the results from various visual function tests. So the results here expresses the percentage of patients who perform significantly better with the system on versus being off. So most patients were able to demonstrate an improved ability to localize objects, and half were significantly better in detecting the direction of motion. So the reason I pulled out this example is because these data were from an observational study of 30 patients. So as Dr. Guy walked us through earlier, the quality of the evidence started as low. However, given that these patients have profound vision loss, when the prosthetic system was activated, when it was actually turned on, they could start to see and perceive light and dark shapes and objects. They were able to have that significant improvement to localize objects to see a direction of motion. So because of that large magnitude effect and recognizing the underlying trajectory of the disease, we upgraded the quality evidence from low up to moderate. And so we presented OTAC that there was moderate certainty that the Argus 2 retinal prosthesis system improved visual function, realized functional outcomes, and the quality of life. OTAC considered this, of course, as well as in addition to a lot of input from patients from the patient engagement team and the economic team, and recommended publicly funding this technology, again, late last fall in November. So after those quick run through those three examples, I just wanted to kind of close and summarize some general advice and reflections that we have on the use of grades. The first is really the need for collaboration and discussion. Our clinical epidemiologists undertake the critical appraisal of the evidence as single reviewers. So we think it's really critical for our team to discuss and debate the grade ratings, particularly when they're just not as cut and dry as those examples like the mechanical thrombectomy and when one is dealing with narrative summaries of the data. We do evaluations of healthcare services and medical devices, and they tend not to be as cut as dry as they evaluate drugs. We don't evaluate drugs at HQ, and perhaps with public health interventions, it may be not always as cut and dry and as easy. And so I think it's very important to have that discussion and debate with colleagues when one's doing the rating, just to kind of talk it out and have that conversation. We also think it's essential to involve clinicians in our processes. We really help to provide a context and deeper understanding of the healthcare condition, not just, we think, just facilitates the interpretations of the results themselves, as well as the grading of the evidence. We find that the summary findings table is a very useful way of presenting the results in the grade assessment. It's what we use to summarize our work when we present to OTAC. I would recommend that using that. And we're also, within our team, also starting to try and use Grade Pro, the free software that one can use. And we've had some positive feedback from within our own team, so we'd encourage folks to have a look at it and give it a try. And finally, I would suggest following the grade working group, either following them on Twitter or joining their newsletter. It's just a great way to stay up to date on new work and just keep informed and connect with other folks who have an interest in grade. And just to sum up from our perspective at HCO, having used it, I guess, all the way back since 2004, we feel it really does provide us with that structured, consistent approach to evaluate and as well as present the quality of the body of the evidence. And in terms of OTAC, grade certainly does provide the important information about the certainty of the effectiveness of the treatment, which is certainly crucial for their decision making. So thank you.
Thank you so much, Sarah. Those are really great examples, and I really appreciate you sharing your experience with us. So at this point, we have reached the point where we will open up to an open Q&A. So I do encourage participants to please post any questions or comments that you may have for the presenters in the chat box, and please try to make sure to send to all participants. I'm just going to move the slide over to our comments and questions slide. And I was hoping perhaps to ask a question of both Sarah and Gord in terms of what your kind of thoughts are on perhaps the level of knowledge or expertise that's needed to use grade in practice.
Well, I guess I'll start. It depends on, when you say use grade in practice, there's two different ways of using grade. One is if you are actually a systematic review author or a government agency such as Sarah's OTAC, or a health technology assessment organization, in which case you need a reasonably sophisticated understanding that allows you to make the challenging judgments that are inevitably part of rating quality of evidence and then ultimately coming to strength of recommendations. On the other hand, if you are a consumer of grade recommendations, so for instance, many clinicians are users of UpToDate, which is an electronic textbook that has over 10,000 graded recommendations. They use numbers and symbols. 1 and 2 is strong and weak. A, B, and C, they're high, medium, and low and very low quality evidence. All those folks need to know is to be able to understand the ratings. So they need to know that a strong recommendation is a just do it recommendation, that if the guideline panel or the UpToDate authors have got it right, all or almost all patients will make the same choice. You can simply say to the patient, here is what I am recommending to you, here's the reason why I'm recommending it, here's how you would use the intervention. And they also need to know then that some recommendations will be on the basis of high, moderate, or low quality evidence, and perhaps then, if they see a strong recommendation based on low quality evidence, to be a little bit suspicious. So that because some guideline panels, we're hoping less and less, but some guideline panels are still attached to previous models of guideline panel decision making, which have sometimes been referred to as GOBSAT, good old boys sitting around the table, where they like to make strong, they like to tell people what to do, even when there's low quality evidence. So they might be suspicious of that. The other thing that it would be very good for users of grade or clinicians with any patients is to be able to understand the results. And that's where the grade summary of findings tables can come very handy, because if it is a weak recommendation, it means that it's a value and preference sensitive recommendation, and it would be highly desirable if clinicians understood the evidence well enough to engage in shared decision making.
Perfect. Thank you so much. And that grade summary of findings table, is there a template available on the website?
Oh, yes. If you go to the grade website, you will be able to find the summary of findings tables. And obviously, I showed one example of it. Evidence proof. You have summary of findings tables, which are a little more compressed than the evidence profile that I showed, but basically provide the number of studies, number of evidence, relative and absolute effects, and the quality of the evidence.
Okay, great. That's wonderful. So our next question here is likely for you, Gordon. Are you aware of certain journals that are using the grade approach in peer review?
Well, lots are using it in peer review in the sense that if a systematic review or a guideline gets sent to a reviewer who is enthusiastic about grade, they will make a strong suggestion that grade be used and grade be used appropriately. So I do a lot of systematic review, or I do a lot of peer reviewed for journals. And of course, if something gets sent to me, then I say, are they using grade? If not, they should seriously consider doing so. And if they do use it, make something of a critique. And given that it's now being used by over 100 organizations and has a rather astounding number of citations, it's generating a lot of attention. Many peer reviewers will be bringing to the attention of the editors in systematic reviews and guidelines the desirability of using grade. And in terms of organizations, so the American College of Physicians is one of and the American Thoracic Society are two that have signed on to grade. They have their official journals for the Annals of Internal Medicine for the American College of Physicians, and they have, the fact that that the organizations have signed on means the journals are likely to insist on it. And one journal has officially endorsed grade in saying that in their journal, systematic reviews and guidelines should use grade, and that's the British Medical Journal.
Great, that's perfect. So I think more informally in a lot of areas, but I think it is being integrated more formally over time. So that's great. Thank you for your response. This question here is specifically for Sarah, and the participant was wondering, in your role, do you receive comments, especially from the public, regarding grade on the ease of understanding?
Hi, thanks. So in terms of comments from the public, we do receive feedback on when we post our HTAs and the final OTAC recommendations. So in terms of the grading, we tend to get more comments from clinicians themselves, and we actively seek out input from the clinicians as we build the report, and just to try and ask them for the best way of communicating our grade results and our certainty of the evidence. I don't think we can actually get questions about the grading from patients themselves, but we try and make sure that when we engage with the clinical experts that we're doing so and we're presenting our results in a way that's understandable for them. We've got quite a few clinicians on OTAC as well, so we're trying to work with them to make sure that when we do present the HTA that it's done ideally using that summary of findings table in a way that they can interpret and understand the certainty of the evidence. Okay?
Yes, yeah, great. Thank you very much. Yeah, that's very interesting. Our next question is, and I might need some clarification here, but was hoping that for a comment on the role of real-world evidence on the recommendations of a drug or a device in addition to grade. So I'm not entirely sure what might be meant by real-world evidence.
I'm quite sure what is meant by real-world evidence.
Okay, great.
Okay, so there is a tension in the methodologic community and in people who bring evidence to the fore about the roles of randomized trials and observational studies, and large observational studies, and particularly in an era of big data where the observational studies may come out of administrative databases. And the position on the one hand is that because randomization is the only secure way to ensure prognostic balance, randomized trials represent a far more trustworthy source of evidence than do observational studies. And we point to a number of instances. One dramatic one is antioxidant vitamins. So large observational studies, which some would clarify as real-world data, because it's not in the context of a trial, it's out in the community. Out in the community, when people did observational studies of antioxidant vitamins, they found unequivocally that people who took antioxidant vitamins had lower rates of cancer and cardiovascular disease than people who didn't take antioxidant vitamins. That was unequivocal and true. People who took antioxidant vitamins had less cancer, less cardiovascular disease than people who did not. Unfortunately, it had nothing to do with antioxidant vitamins. When randomized trials were done, there was, if anything, a harm signal and certainly no benefits in reducing cancer and reducing cardiovascular disease in those who took antioxidant vitamins. So what's the explanation? The explanation is people who take antioxidant vitamins are a different set of people than those who don't, and they start out with a lower risk, and that's why there was this association. And there are many, many examples of this sort of phenomena. So if by real-world data, as many do, people mean observational studies, or particularly now observational studies from large administrative databases, we continue to be very concerned by prognostic imbalance, as was dramatically demonstrated in this antioxidant vitamin. So GRADE has not shifted from its position. Randomized trials start as high-quality evidence. Observational studies, including the so-called real-world evidence, start out as low-quality evidence, although, as I pointed out, if the effects are very large among well-done observational studies, the evidence can be rated up to moderate or even high quality, and if there's a dose-response gradient, the evidence can also be rated up in the quality judgment.
Okay, great. That's perfect. Thank you. And I think that may have really gotten to our next question. So I will move on, but if a participant would like some clarification, just please let me know. So our next question here is specifically for you, Gordon. Do you think there is still a place for Oxford levels of evidence system in making guideline recommendations?
I can give a very succinct answer. No.
Perfect. That's very, very clear. Thank you. Thank you very much. Would you like to expand on that?
Well, if you talk to some of the people who were who made up the Oxford, Paul Guglasio addressed this recently. It was not intended for the same purpose as GRADE, and the leaders among the people who developed this, Paul is one, have been very active in helping with the creation and refinement of the GRADE approach. the grade approach is much more clearly designed for overall ratings of quality of evidence and strength of recommendations, and you have this widespread endorsement, and for those who are making the ratings, for the systematic reviewers and guideline developments, you now have this 18-part series in the Journal of Clinical Epidemiology. For clinician users, you have this 6-part series in BMJ. It is, and you have the 100 organizations that have adopted it. So really, they're in completely different worlds.
Perfect, great. Thank you for that explanation. We have a question specifically for Sarah, and we're wondering in the HTA context, how does grade link to the evaluation of cost effectiveness? For example, strength, quality of evidence in terms of cost effectiveness with regards to making a decision or recommendation. So I think how do all of those different perspectives, I think, fit into how that decision gets made?
That's a very good question. I guess at the moment now, we don't really have any kind of formal link in terms of our health econ team, in terms of linking that strength of the evidence that comes from the clinical component into the economic work. I certainly undertake scenario analysis and other kinds of methodologies to model that certainty of the evidence. So within HQO, we don't have a formal way of using grade within the health economics part of the HTA.
Very interesting.
I don't know if Dr. Guy wanted to comment on whether grade was working to develop any kind of formal health econ grade or anything like that.
So, sorry, I'm not sure. What exactly is the question?
Well, I just wonder, is there formal kind of grade guidance on health economics? I know you've asked that question at OTAC a few times.
Yes. So, in fact, there is one paper in that Journal of Clinical Epidemiology series that provides initial guidance, and we are working on a second paper. And there is also a paper in the British Medical Journal series. So, although when you looked at it, it certainly doesn't answer all the questions, and the other thing is that all the papers I just mentioned focus on cost and how to deal with cost, but much of economic analysis involves modeling. So you have decision analytic modeling. GRADE is still working on developing guidance for the decision modeling used within economic analysis, which we hope will be appearing before too long.
That's good to know. Thank you.
And in the meanwhile, Sarah, I am very interested in when we develop these guidance. Examples are very important, so I'd be happy to discuss any examples that come up that you would like to.
Super.
Wonderful. So I think we are slowly approaching the end of our time, and I'm hoping to be able to get through one or two more questions before we move on. So I will ask then. More recently, we have more non-inferiority clinical trials. Should we have a special or different consideration when assessing them with grade?
The only special considerations are that there are additional risk of bias or validity criteria for instance, in a non-inferiority trial, you want the conventional treatment to be administered optimally, and you might not only want an intention to treat, but a as-treated analysis. After that, it's exactly the same. You look at the benefits, you look at the downsides. So really, when you come to looking whether the trial is structured as a non-superiority or non-inferiority, in either case, you look at the benefits and you look at the downsides and you trade the two off. So at that level, no difference whatsoever.
Wonderful, great, thank you. And then I think one more question before we move on, and hopefully we will be able to get back to a couple more near the end as well. But do you believe that Cochrane review authors do not need to assess imprecision as the same way as we do for guidelines?
The Cochrane reviewers are not supposed to be making recommendations. This might be a very sophisticated question in that grade distinguishes between the judgments of precision that happen in the context of a guideline, which involves value judgments between the benefits and the downsides, and within the setting of a Cochrane review, they're not supposed to make recommendations, so things needn't be, well, one could argue that they shouldn't be, explicit value judgments shouldn't be made because that should be in the domain of the guideline developer. So the assessment of precision should be at least somewhat, should differ. So it's not that Cochrane reviewers should not be making comments about precision, but the way they are framed and assessed might differ to some extent from that within the guideline context.
Okay, very interesting, thank you. So I am going to, as we are approaching the end of our time, I am going to continue with our last few polling questions that we have. So thank you to everyone who has still tuned in. We would like to ask our audience today if this method or tool, so using grade, could be useful in your own practice. So response options include a range of very, somewhat, or not useful, or perhaps you are unsure or you don't know. Again, I would like to encourage you to, after you've selected your answer, to please hit the submit button at the bottom. So I will leave that open for a little bit, but I would like to mention that most or everyone that has responded thinks that this could be very or somewhat useful in their day-to-day work. That's really great. At this point, I would like to take some time to share our post-event survey link for this webinar, which we will also post in the chat section for you to access. Your feedback is very important to us, so please take a few moments to complete the survey and provide any feedback you may have on this tool, as well as on our Spotlight webinar series overall. So we welcome any feedback, and we really use this information to help inform the webinar series itself, as well as to select methods and tools to feature in future sessions that are of interest to our audience. So again, that short survey link will be posted in the chat section, and we would really appreciate if you could take a few minutes to respond. We have one more polling question before we wrap up, and this one is a little bit different in that you can actually select all answers that apply to your context. And so we're just wondering what your next steps might be. So whether you intend to access the method or tool presented today, if you plan to read the summary of grade on the NCCMT website, if you're considering to use grade in your own practice, or if you plan to tell a colleague about the tool that was discussed today. Again, we appreciate all feedback, and it's very helpful for us. So we are seeing that there's lots of people in our session that are still with us today that are going to access the tool, read the summary, possibly use the tool, or tell a colleague about what they've heard today. So that's really great. Thank you very much. So before we just wrap up, just to note that if there are any more questions or comments, we would be happy to try to relay them to our presenters. If you have any questions after we close up the session, please note that the emails are posted in the here and in the general chat section. Also, if you enjoyed today's session, please do consider joining us for our next Spotlight webinar series, which is on April 20th on the Getting to Outcomes approach. Which is also another one of the most popular tools that are available in the NCCMT registry. So if you are interested in this topic, we invite you to register and join the session, and the registration link will also be posted in the chat section. So given that we have a couple more minutes, I do have a couple more questions, and I think these two here are very related, I think, in terms of what they're asking. In your opinion, can GRADE be used for phylogenetic studies or disease outbreak analyses using models?
If it's to make recommendations, yes. So sometimes models are simply modeling what can be expected in an outbreak and how it's going, if it's on the upswing or the downswing. That's a different sort of question. If the question is a management question, you know, should you manage it this way versus that way, then the answer is yes.
Okay, great. And I think also another question here is, can GRADE be used on syntheses of evidences or so policy briefs?
Yeah, for sure. So syntheses of evidence, we believe, should be systematic reviews, and there have been, McMaster here, where I work, has been very much pushing the use of GRADE within health policy and in general evidence-based health policy. So sure, it can be one. We'll have to accept that much of the time the evidence is only going to be low quality, and sometimes that makes people uncomfortable, but that is simply the way it is, and people need to face it. Doesn't mean that decisions could be avoided or put aside, but it means that the limitations in the evidence need to be acknowledged.
Interesting. Yeah, that's a good point as well. I would also like to take a quick moment to let you know about a number of our other webinar series that we host here at the NCCMT. So as you know, the Spotlight series features knowledge translation methods and tools that are available in our registry, presented by the author of the method or tool, as well as by a user of their experience using the method or tool. We also have the topic-specific webinar series that features resources that can support evidence-informed decision-making in specific areas of public health. We have our online journal club, which is a small group format webinar that gives you a chance to practice your critical appraisal skills with experts and peers. And the peer-to-peer webinar series, which shares success stories and evidence-informed decision-making from practitioners across Canada. So if you're interested for more information on these different series and to sign up for sessions, you can visit the link posted in the chat section or visit our website. And this really brings us to the end of our session for today. So thank you a big thank you to our presenters for their great overview and insights today. And thank you also to everyone that has joined us today. So I will pass it along to our presenters in case they have any more comments or final words for the audience today, and then we will wrap up.
It's Sarah here. Just want to say thanks for the opportunity to share our user experience. It's been great connecting with folks. If anyone has specific questions about the HCA program here at Health Quality Ontario, happy to take emails or things like that. So thank you.
My pleasure as well.
That's great, wonderful. Thank you, everyone. And I think, I guess, with Sarah's comment, if you are interested in getting in touch, please let us know, and we would be happy to connect you with her. And thank you again for everyone who has joined and participated. It made for a really great discussion. Thank you very much, and we really hope to see you at our next session. So have a wonderful afternoon.